Hello, everyone, and welcome to our webinar at NYU Langone Orthopedics. Um, I'm very excited about this webinar. The title is State of Modern Technology in Total Joint Replacement, Robotics, Augmented Reality, Navigation, and Kinematic Balancing. I'm Morteza Meftah. I'm co-director of Robotic Assisted and Precision Technologies at NYU, along with Dr. Matt Hepinstall, and we have great panel of faculty for you tonight. Dr. Vinay Aggarwal and Dr. Claudette Lajam will be joining us for this webinar tonight, and we'll go over the topics. I'll start with discussing patient-specific alignments in total knee replacement and modern trends. And after that, we'll have Dr. Aggarwal discuss robotics in total knee arthroplasty, looking at the differences and future directions. Then Dr. Hepinstall would discuss robotics in total hip replacement, the current debates and solutions. And finally, Dr. Lajam will go over the metaverse and everything XR in orthopedic surgery. And then we'll have at the end Q&A and discussion. These are my disclosures. Nothing is pertinent to the talk tonight. So if you look at the reasons for revision knee replacement in the modern era, we know that it poses considerable burden on the patients in healthcare with known entities such as aseptic loosening and failure fixation, infection, of course, pain and stiffness. But we still have significant amount of percentage of patients that are still not happy. And those are the ones that X-ray looks great, but the patient doesn't feel that good. And we know that the inappropriate ligament balancing does contribute to a high percentage of early revision total knees. Some of it could be near extension instability, especially on the medial side. And there begs the question, what are our ligament goals and balancing as we do knee replacement in the modern era? If you go back to the target for alignment and ligament balancing in the past decade, we started with measure resection, with fixed angles and gap balancing, which that fixed tibial cut and the femoral rotation were based on equal gaps in flexion and extension. And in the recent years, we've evolved into more of a personalized patient-specific approach with kinematic alignment, trying to restore the pre-disease state of the knee alignment and gaps. And from that philosophy, we have restricted kinematic alignment and inverse kinematic alignment. And the idea is sometimes these cuts are independent, the preparation of femur and tibia. And of course, when we go over some of the technologies, they could be linked as we do some of these techniques. And so the journey to the forgotten knee continues to close these gaps of dissatisfied patient. With the evolution of technologies and some of the precision platforms that we have, and they're gaining increase in usage, we've evolved from a fixed alignment approach, the fixed targets for alignment with variable soft tissue release, to having fixed gap targets with variable alignment within boundaries, therefore the restricted kinematic alignment. And the idea is to avoid soft tissue release if possible. We know that extensive soft tissue release causes a lot of pain and swelling and therefore difficult recovery. Technology can improve precision of implant positioning. There's no debate about it. The issue is that we can be very precise, but the accuracy of goals have not been really identified. The navigations that we can use with soft tissue data, it gives us a lot of data in terms of adjusting the overall extremity, the soft tissue for balancing. Of course, robots can make very precise cuts. But as I mentioned, the goal of the alignments and gaps are not really well defined. And therefore, with these platforms, we have opportunity to be more specific with our alignments and goals. So why not everybody uses any form of technology? If we could look at the recent literature, only 18 to 20% of joint replacement surgeons use some form of technology for their total knee replacement. Some of it are related to unfavorable reimbursement policies and bundle payment cases, but majority of the uh, lack of adaptation is because the benefits are not widely accepted. And we'll go over some of the literature in terms of the use of technology and the result of it. In the past years, we've seen plethora of new technologies started from 1970s. And in recent years, almost all strategic implant companies have some form of navigation or patient-specific alignments. And of course, the robotics have gained quite a lot of interest in the past few years. And then we have the patient-specific cutting guides and implants that are based on some form of preoperative imaging. They're easy to use, but they don't take into account the kinematic data. And there are a lot of very interesting technologies on the horizon in terms of smart tracking devices and cameras, which could be customized and less issues with line of sight and few other hurdles that we have with the current technologies. And of course, the augmented reality headsets, which are becoming a lot smarter and smaller and user-friendly, and Dr. Lajam would go over that. Some of the outcomes of robotic total knee replacement I can share with you. There are a variety of different published literature out there that don't show any difference. I've highlighted the ones that I found interesting, and they do show some difference. One of the early ones is from Bob Merchant, which looked at the 2-year data between Mako total knee replacement and conventional total knee, and he showed that there's significantly less or lower rate of aseptic failure in robotic total knee replacement. OFA's group looked at a large national database between 2010 and 2017, comparing robotic total knee versus conventional. And in the robotic knee group, they had lower rates of 90-day readmission, as well as lower risk of revision at 1 year. And conventional total knee had a higher risk of MUA at 90 days and 1 year. So if you go back to current trends of alignment, the quote unquote non-traditional methods of the current techniques would be the restricted alignment or personalized alignment, calibrated technique, which are gaining more interest. And as I mentioned, the precision of the robotic platforms can help us execute the plan. One of the interesting things that I want to highlight tonight is the idea of CPAC classification, which is a coronal plane alignment of the knee. McNessie's group described these in very detail, and basically based on the 2 angles of the lateral distal femoral angle and the medial proximal tibial angle. You can categorize knee phenotypes into 9 groups. The arithmetic hip knee angle, which is the difference between these 2 angles, defines the coronal alignment of hip knee angle. A negative value would be varus, and a positive value would be valgus. And the joint line obliquity would be addition of these 2. And that puts the knee phenotype into either apex distal, neutral, or proximal. And as you can see, now you have 9 phenotypes of knees, arthritic knees, based on these 2 parameters. In their study, they found that majority of the knee phenotypes fell into the apex distal category, which would be group 1, 2, and 3. Avari group analyzed this concept in 115 restricted kinematic alignment patients, looking at their CPAC classification, and they put them into 3 different categories based on the varus deformity. And what they found is that they had a really significantly different higher patient satisfaction in restricted kinematic alignments that had the CPAC classification included. and their patient satisfaction improved from 81% to 93%, which was very interesting. So in general, in the current literature, the um, the kinematic alignment or restricted kinematic alignment has the potential to improve short-term outcome. Reproducing the corneal alignment um, seems to make a significant difference by allowing us not to over-release or avoid soft tissue release. And one of the other interesting things that I found that from Johan Bellman's group is to understand the pre-arthritic corneal alignment of the knee, which could be a game changer. In their publication with with Jan Victor's group, this is a very sophisticated formula that if you calculate some of the alignments, you can actually predict the pre-arthritic corneal alignment of the knee. And the study that they did, the more satisfied patients were the ones that had more of these pre-arthritic corneal alignments restored. We looked at our own NYU data within our robotic-assisted total knee replacement, and we were trying to find the trends in the functional outcomes at 3 months and 1 year, and try to figure out are there any correlations between the CPAC classification and our outcome at NYU. We have currently about 300 plus patients with full data at 1 year. We looked at their intraoperative bony resection and alignments and gaps, basically everything that the Mako robotic platform provides for you. And we looked at the pre and post operative corneal alignment based on the full length EOS images. These are basically our demographics, which is very typical of orthopedic patients. The technique was a restricted kinematic resection, which is the boundaries of tolerance for surgeons. It's usually around 1 degree of valgus to 5 degree of varus. And the interrotation of the femur varies between 2 degree internal to 4 degrees of external rotation. And the goal of overall alignment was to be 0 plus minus 3 or 4 degrees. And again, the idea was to avoid soft tissue release when possible. We also looked at different types of implants, looking at CR versus PS liners. We categorized the patients between 3 categories based on preoperative alignment into varus group, which are more than 3 degrees, and neutral group, which are 0 plus minus 3 degrees of hip knee ankle alignment, and valgus, which are more than 3 degrees. And we looked at the 3 months and 1 year data. And as you can imagine, most of our cases fell within the CPAC classification of 1 and 2. In terms of results, interestingly, most of surgeons put the tibial base plate at 0 degrees for valgus knees. And that's understandable. We want to avoid reproducing valgus alignment for these patients because majority of them do not tolerate valgus alignment post-op. The varus knees had greater variability in proximal tibial resection angle, which makes sense because that's the main attribute that we can adjust with the robotic platform. Here's the interesting part. When you look at the varus knees, the phenotypes that were kept into their CPAC classification had higher Coos Junior score at 1 year, which was significant. In valgus knees, the ones that had less valgus femur, therefore less hip knee angle, had higher Coos Junior score. We didn't find any significant difference between CR and PS liners. And one of the cases that I just recently did, I would like to share with you my workflow doing a personalized patient-specific restricted kinematic alignment. This is a 57-year-old female that underwent left toe knee replacement about a year ago. She was very happy about it, and she was indicated for right total knee replacement. When you look at the actual overall alignment and calculate the CPAC classification, she would qualify for a category 2. This is the intraoperative flow. When I'm using Mako platform, I usually start with my slope to be about 4 degrees for CR knee and flexion of femur about 3 degrees. Now we have the opportunity to pre-plan prior to start of surgery. I tend to start with same resection of the proximal tibia of 7 millimeters and 6 millimeter of the distal femur. The femoral rotation, I usually start with 6 millimeter posteriorly, but then I adjust with a little bit more external rotation to close the gap posterolaterally, and I try to match with the trochlear groove. And so the idea is to have 1 millimeter, 2 millimeter gap opening on the medial side and 2 to 3 millimeter gap opening on the lateral side, both in extension, 20 degrees of flexion, 15 to 20 degrees of flexion. Of course, that around 90 degrees of flexion. If you can see on the right side, the preoperative limb varus was at 6 degrees. And with the planned varus, we want to keep that patient in the same category of CPAC. So the planned overall varus would be at 4 degrees. With the fine tuning throughout the range of motion and using spoons to measure gap, these are the final numbers for extension, around 19 millimeter in the medial, 20 millimeter lateral, same for the flexion. This is a robotic platform that performs the cut. This is a little bit of a close-up. My personal, and this is the pedal tracking, which you can see it has excellent tracking. Most of the time when I use a robotic platform, I found that my cuts are so precise that I can use press-fit implants. And again, my anecdotal use of robotic technologies with the restricted kinematic alignments, I see that patients are much happier post-operatively and less swelling, and they have better outcomes. Thank you very much. So now I'm going to have Dr. Vinay Aggarwal talk about robotics and total knee arthroplasty and discuss the differences and future directions.
Okay, thank you so much, Mort, for putting this panel together on with Matt. We welcome you from NYU Langone. We're really excited with the adult recon faculty. Happy to be part of this panel with Dr. Lajam as well. And a lot of what Mort has talked about is going to be reiterated in my talk here, but I'm going to take a little bit of a different spin on it and try to focus you guys in on some of the different robotic competing technologies out there and where we're going in the future here. But obviously, we always like to start with some background here. So I'm going to just take control over here of the screen. And we're going to start with our outline. So we're going to talk about a little bit of background. We're going to say, our second most important topic here is, are all robotic computer-assisted total knee replacements done the same way? Obviously the answer is no, but let's talk about a little bit of the nuances, and then we'll see what the outcomes. I'm not going to harp on this too much more. It went over a lot of good outcomes here. And then where are we headed towards with technology and total knee replacement and partial knee replacement? So some background here. There's no question that people will ask this, are robotics necessary in total knee replacement? Your hospital administrators, your patients, even your co-surgeons. The internet would certainly tell you so. How robotics is helping change patient care. There's no reason why you wouldn't think that robotics are necessary. Even from the surgeon standpoint, we're looking at robotic knee replacements, and we're doing literature searches and finding that, in general, astronomical increase in the surge of literature being published on this topic, even in the last 1, 2, 3 years. So Obviously, total knee replacement, very effective for end-stage OA. However, Mort has touched on this dissatisfied patient population. And aseptic loosening is one of the leading causes that continues to plague us here. So there's clearly room for improvement. We talked about multiple alignment philosophies, which I think are going to be really interesting using robotics and technology going along what Mort just talked about. But there's also implant designs. And then there's the computer assisted surgery piece, which we're going to talk about right now. How does computer assisted surgery help you and what might it do for you? So what are the trends right now? Well, this is from the last decade and a half. Where we're clearly seeing a massive increase in the utilization, despite the fact that Moore pointed out that it's still not 100%, it's going up by quite a lot. And this is looking at computer assisted and robotic assisted. If you were to extend these curves out for the last 8 years, I would guarantee you that they would be going up at even higher rates. So what about the non-specialist surgeon? I think that when you look at non-arthroplasty fellowship trained surgeons, these tools are becoming much more applicable and also usable, user-friendly, and quite frankly, marketed and advertised towards the everyday generalist as well. And we'll debate whether this is a good or bad thing, but I think that it's certainly true that it's not going anywhere. Nonetheless, in addition to that, the patients want it, right? It's not just about the surgeons. It's about the fact that if you do a Google search, this is a Google Trends analysis, patients will look up robotic knee surgery, right? They will see, is this the new frontier? Is this something that I should be getting for my knee replacement? Why am I not being offered it? And so you just go to the local office and you sit down for 10 to 15 of any of our patients that are on this panel. The faculty will all tell you that robotics is being pushed to the patient as well. And it's certainly being asked to us in the office setting. What are the main advantages then? Well, Mort definitely touched on the precision of the bony cuts. You saw how precise it was, therefore being able to use cementless implants, therefore recreating our femoral sizing, our rotation, our condylar offset to a much more accurate degree that we want based on our preoperative plan, and hopefully translating to a reduction in complications. So we're going to see about aseptic loosening instability, but what about the chronic pain and dissatisfaction piece that we're trying to solve? Are we actually solving that piece? Okay. So some would tell you that there's very advertised advantages out there and single surgeon experiences published, but are we getting the minimal clinical important difference? Several studies have shown that the answer is yes, but I'm going to go through some of these. Most of the ones that are clear about the advantages of robotic knee surgery are based on radiographic targets. Radiographic precision through bony cut accuracy is number one, the most provable time and time again in the literature advantage of robotic and computer assisted knee surgery, right? That's the clear winner here. We are clearly better at making our bony cuts more precise, getting these implants in the positions that we want to. And we're going to have to see whether that translates into the rest of the world here. But it is important, right? It's important to get our implants where we want them to be. If we're going back in time a little bit here and looking at traditional literature, Merrill Ritter's landmark article, some stuff from the Mayo Clinic, it would tell you that a deviation from neutral mechanical axis is dangerous. Now, Mort just told you that that's not true, and I would agree with him that it's not true. But what is true is that you're hitting your target, right? The ability to hit your target better is what we're talking about here. And when we see studies using randomized controlled trials with computer-assisted surgery, you can clearly see the green. You're hitting that target mechanical neutral which is what they were shooting for here, compared to custom or conventional jigs. You're clearly hitting that target with the green line going across 90 better. In this study, and again, once again, in this study, you're getting that coronal tibial femoral angle in a randomized computer-assisted study much closer with those patients compared to conventional surgery. Okay, so now background is done. Let's talk about what the different types are. So it's a lot of stuff out on the market. We're going to break it down. There's a very good review article for any of those of you who are interested in the Yellow Journal here by Nick Puisi's group here, looking at whether all of the robotic assisted surgeries are similar, different, and what the history is really of them. So if we go back in time and look at the history, there's actually several robots that have now kind of developed into the newer age. And right now, if you look at the main ones, if you focus on these two boxes here, I think that these are the most important things: the technique and the image usage. So we have Think Robot, we have Zimmer Biomet's robot from Rosa, we have Stryker Mako, which has obviously been out on the market for a decade plus. Smith and Nephew's Navio, now rebranded with newer technology, the new Cori robot, and Depew. This is an older slide here, but Velis is their new one, which I'll talk to you about in a second. So if we look at, obviously, platform, all of these, for the most part, nowadays are going to be closed platform, except for the Think robot. That's an important piece of this. Robotic technology, the implant companies are no dummies. They are trying to get you to use their implants through their robotic technology as well. So they go hand in hand. So the majority of these are going to be closed platform. However, the techniques are slightly variable. Okay, there are saws, there are burrs, there are cutting guides, there are, and then when you look at image guidance, there are CT image based, preoperative CT, intraoperative X-ray based, intraoperative imageless. So there's a lot of things that we need to parse out here. The first thing I want to talk to you about is whether it's a passive, semi-active, or active robotic system. What does that mean? So the passive system is the one that is directly under the guidance of the surgeon. The system just assists with the procedure, but the surgeon has to tell everything to the robot, and we use that to position our cutting blocks where we want them. Think of this as kind of navigation or navigation on steroids when we're talking about ROSA. Okay, so this includes IntelliJoint, Ortholine, ROSA as the robotic platform, but it's really thinking of it as a navigation where the surgeon can tell the computer-assisted surgery robot where to put our cutting blocks and then do the surgery through our own hands. Semi-active, what does that mean here? So that's where there is controlled robotic tools within the system. It restricts you within a task. A predetermined frame is utilized, and this goes along with things like Mako, Cori, and now the Velis. I'll get into that in a second here. And then we're talking about active. Okay, so this is really not taking off in the United States yet. Active technology and robotic total knee replacement is very exciting. It's very interesting. It's very, obviously, it goes without saying that with urology and Da Vinci robots doing a lot of active surgery, we are headed in this direction per se. But this is where the robot's performing the surgical task, drilling, milling, sawing, etc. We haven't really taken off, but the Think robot was one of the forefronts on this. Okay. So let me just, okay, good. So image-based versus imageless. So when we're talking about image-based, obviously we're getting a three-dimensional or sometimes a two-dimensional construct that then we can utilize from a preoperative standpoint to plan, like Mort showed you here, where our implants are going to go. Whereas imageless is a combination of registration techniques intraoperatively. So that's surface registration, for example, kinematic registration. The information that you give the computer is processed from the surgery, and that creates a map, if you will, of where the computer sees the knee in space. The knee position and cutting jigs are then positioned, and reference planes are utilized so that we can get specific targets and cutting depths, resections, angles, etc. Still a little bit of lag. Sorry about that, guys. Image-based is obviously the downside of being cost, radiation, and then the wait time between the imaging and the surgery. And then the good thing is that it does allow for pre-op planning if you need anything special done beforehand. With imageless, you don't need imaging, you don't need that extra cost for radiation, but it's a little bit quicker in the OR. But is it giving that extra level of accuracy and precision that you're looking for? So what do they look like? Well, I'm going to tell you one thing for sure, that going forward here, robotics in any form, any vendor, I like to say that it's kind of like the 90s boy bands or the family of the Kardashians. As we get further and further along in our iterations of these, they're all starting to look a lot more similar. Okay, so they start out very different, but as we become, progressive, one technology is going to take from another. They're going to borrow ideas. They're going to share. And it's happened in the last 1 year, 2 years, 3 years. A lot of these technologies are kind of morphing into each other and having ultimately a similar thing that we're working with, and that is the precision accuracy with the cuts and the ability to balance our soft tissue gaps and plan how we're going to be tensioning our ligaments to get the knee to behave the way we want to. All right, good. So let's go through individually each one of these. I know a lot of our faculty panel have utilized many of these technologies, but many of our viewers may have not. And I'm just going to highlight some of the big differences here for you. So as Mort mentioned, he demonstrated the Stryker Mako robot. We are using a semi-active system where there's a haptic guided saw. So you can see that on the top left. It restricts you, as you can see on the top right, as far as the zone that you can cut the bone in. And it is very nice. It gives you a system of red, white, green as far as level of resection of the bone. And then you can also balance your gaps, as Mort showed you. You can look at the ligament tension. You can look at the gaps in terms of millimeters. And to a millimeter, you can get how loose or tight you want to leave a particular compartment of the knee. And you can see that being done here. Functional balancing, using different alignment strategies. As Mort showed you, you can balance it to your desire. Zimmer Biomet's ROSA system, a little bit more, like I told you, a navigation tool on steroids. Because it is done through custom cutting blocks, you are still performing the surgery entirely with your own hands and with your own conventional tools. What does that mean? You're still using your own saw blades, okay? You're still using your own retractors. You are just putting the robot's, tools to use when you're positioning the custom cutting jig in where you want it to be. You can see that here on the top left. And then, like I said, all of these systems are now allowing you to balance your soft tissues to a T so that you can play with your gaps, play with your varus valgus alignment, and obtain valuable information about how we are leaving the OR. And this is a femoral rotation tool where you can do a gap balance technique as well using the robot. Once you cut your proximal tibia, distal femur, you can then assess your tension and rotate your femur further with the robot to get additional information that way. DePuy Vallis, one of the newer ones on the system. Clearly, again, a more semi-active handheld saw attached to the robot with some haptic feedback. And again, going back to the same principle here, you do have the ability to take the knee through a range of motion, look at how it's tracking in terms of alignment, coronal plane, sagittal plane, flexing the implants to a degree, and also balancing our soft tissue gaps, as you can see here in the bottom right. Corey, a little bit different. You can see that it's a burr-based system. So no longer are we using a saw, a burr-based system, but still using intraoperative registration, no preoperative imaging, very small platform as far as how big the actual robotic system is in your operating room system. You are seeing how much bone you're resecting there based on the robot and the registration. And again, you have the ability to balance. Corey's Omnibot system, another semi-active system, but this one is interesting because it uses the robot to balance the gap intraoperatively. So in other words, it uses the robot to tension, and that's one of its only robotic systems that actually has a robotic tensioner that's attached to the robot as well. Most of these systems are using manual tensioning or spoons, as Mort showed. This one actually has a robotic powered tensioner system for your gap balancing technique. It's really interesting. If you look at Nick Puzzi's articles from before, the clinical history is fascinating. For those of you who are interested, this is an open access article going through the timeline of ever since the very first robots that Mort showed in the 80s down into the 90s with RoboDoc, etc., and now transforming into DePuy Vallis and beyond. So what about the outcomes? I'm not going to harp too much on this because Mort did go over this a lot. Let me just minimize this here. So the main question is, does robotic assisted surgery assist us with implant positioning? I talked to you about the degree of precision. If you look at many randomized control trials through this meta-analysis, the answer is clearly yes, right? You see that all of these bar graphs, for the most part, land on that, the left side of the line there. Now, you can say that, well, some of the box plots overlap one, and therefore it's somewhat equivocal, but none of them have their means or medians to the right of the line, which is telling. We still need to do high quality randomized control trials nonetheless. But I'm going to go over, this is a couple articles where they would say no clinical benefit, right? Robotics at 5 years, 78 total patients only, but 5 years, no clinical benefit. This is a study, another one that's saying there's no difference out of Oxford knee scores and revision rates. Here's a study that we did at NYU where there was no difference in the forgotten joint score, Coos Jr. score at 1 year. And yet there are many studies that will still tell you that there is clinical benefit outside of the precision realm. This one with Dr. McCauley, this one with Hutch Huddleston at California, lower revision rates, lower mechanical loosening rates, and overall revision rates reduced when we're using computer-assisted surgery at 5 years. Okay. However, does the CT scan add value? That's another question, right? I told you there's different nuances to the robot. Does the CAT scan add value? Well, this study said that looking at CT-based versus CT-free computer-assisted surgery, there was no difference, which was interesting. It was a small cohort, but this has been repeated multiple times, saying that CAT scan may not add as much precision as you would think, but it's still a nice planning tool for sure. This is another one, no difference in knee scores or range of motion. So no clinical difference using the CT versus CT-free navigation. And then this is a study looking at computer-assisted surgery versus non-computer-assisted surgery and breaking down CT-free again versus CT-based. Both groups of using navigation were better than conventional. This was a RSA study. They were looking at micromotion and subsidence. This just goes to the point that no matter what technology of robotics knee you're using, CT-based or not, you're going to have a more precise cut. And therefore, we may be going towards cementless implants for good in the appropriately selected patient because there's less subsidence, less micromotion than our conventional group. But as you can see here, the two CT groups did not have much of a difference, right? CT-free versus CT-based. So what's the problem with all these studies? The different types of computer-assisted surgery have unfortunately been commingled throughout the literature. The trials are small, they're underpowered, and it makes subset analysis very difficult. So it's hard to make too many conclusions. You look at this, 775,000. Wow, that's a lot of surgeries in the registry. Only 1,000 were image-based total knees. So very small percentage. So let's talk about so far, what have we learned here? The conclusions I draw from this are that technology and total knee replacement is clearly more accurate and precise when it comes to radiographic parameters. There's still equivocal data regarding revision-free survivorship. We're waiting to see if there's ever going to be a significant gains in functional outcomes. I think the trouble is that we may not have the precision tools to ask our patients about this yet. We're still learning. How do we ask the best questions to ascertain whether robotics is truly making a difference? Are the outdated questionnaires truly just that outdated? And then imageless versus image-based. I think that they both give you surprisingly good radiographic outcomes, but comparisons between the two are quite underpowered to make meaningful conclusions about them. So what's the future hold here? Robotics, I think, are going to be inevitable. Okay, so I think that many editorials, Faris Haddad has written about this for the uni groups as well, looking at the AAHKS membership. That's the American Association of Hip and Knee Surgeons. Clearly, many surgeons are using this at an increased clip, and 73% said they're using this because of increased precision. The intraoperative registration for imageless, dependent on the accuracy of the operating surgeon inputting correct data points, whereas image-dependent systems allow time to pre-op plan. The benefit of this, imageless versus image-based, I'm going to harp on this again, additional cost, preoperative imaging, radiation risk. We're trying to weigh that. Is that worth it? Jess Lahner's experience, I think, is very interesting. If any of you have time to read about this, this is in the Joey journal here. Ira Kirschenbaum runs that. It's a personal journey of his from Mako to Navio to Rosa. I'm not advocating for any of these robotic systems, one over the other, but it's just interesting to see how somebody who's very experienced has gone through and traveled through this journey of different robotic platforms over many, many years. But his main take home here is that I think that we may not even fully yet appreciate robotic knee surgery. Many emerging technologies are still advancing faster than we understand them. The panel here is clearly trying to do a good job of understanding them. And in 2021, 2022, I think robotics has changed the paradigm of knee replacement surgery. The future is bright, guys. I think total knee replacement is changing. This is what Dr. Lajam is also going to be talking about, augmented reality. And one thing I want to harp on is that data collection from these platforms is going to transform the way we analyze our patient outcomes. So with that, thank you guys. I appreciate the time to talk about this. And hopefully you guys learned something from this talk and this panel tonight. Thank you.
Thank you, Vinay. That was a great overview and comparison of our current platforms and total knee. Now we're going to hear from Dr. Matt Hepinstall about robotic and navigation total hip replacement, current debates and solution, and he will take over the moderation on this point. Matt.
Great. Thank you, Mort, and thank you, Vinay, and Claudette for joining the panel as well. So I think the take-home point that Dr. Aggarwal ended his talk with, in terms of basically, I'll articulate it differently. We've come to technology for accuracy and precision in the goals that we used to have when we did manual surgery. But the more that we get our hands on these powerful tools, the more that we realize that we should potentially reconceive what our targets are. I think that's going to be, the tools do for you things you didn't even imagine they could or would when you first thought you needed them. I think that's going to be a recurrent theme in our talks today and probably in the years to come. So I'm going to talk about robotics and navigation on the hip side of arthroplasty. And I do have disclosures. I've worked with a few different companies that are in this space, but I'm widely conflicted, so I'll try to share my bias around. So we'll kind of talk about the need for technology in hip arthroplasty, the history, the current offerings, what's sort of new, what matters in all this, and what might be next. So what's the need for robots in hip replacement or technology? Mechanical causes continue to dominate our early revisions. And, early revisions are obviously the ones that we're most concerned about. These are patients who expected their hip was going to last them 20 years and they're back in the operating room in less than 5. So these are the things we're trying to prevent. So early loosening of a femoral implant and fracture, basically problems with bone preparation account for about 38% of our early failures. Problems with dislocation of the device or irritation of the psoas tendon, sort of biomechanical problems where the length or offset are wrong and the tendon's irritated, or the combined version of the implants leads to impingement and dislocation. Again, a biomechanical problem, a mechanical problem, something that maybe precision technology can help us address. Even metallosis, which is a problem where two metal parts rub against each other, whether that comes from a bearing couple or whether that comes from a trunnion, the connection between a modular ball and the stem of the femoral component. That comes from basically fear of biomechanical issues. We introduced metal on metal implants to have large diameter balls to reduce dislocation risk. We have modular heads on stems so that we can alter the length and offset and try to get the leg length right. And so basically our challenge is getting the biomechanics proper account for a large percentage of our failures as well. And then there's, of course, the bugaboo of infection, which is not a mechanical problem and at this point probably cannot be addressed by robots or navigation. But you can see the majority of our early complications are mechanical in nature. And so we're looking for tools to help us do these operations more reliably. So what's the history of these tools? As has been alluded to before, the RoboDoc group, which was a group with IBM in New York and also out of UC Davis, created the first active robot for joint replacement. It was first introduced to assist with the femoral component preparation and hip replacement. And this was before navigation, actually. And so they didn't have a good way to track bones in space. And so patients underwent a surgery to implant what are called fiducial markers and metal bits near the surgical site before a CT scan was done, and that would then allow there to be landmarks, and you could figure out where the bones were in space relative to these fiducial markers. But a large robotic arm was used. It was rigidly fixed to the patient with pins, so the limb couldn't be moved, and then the femur was machined to accept a cementless femoral component. The goal here was to optimize cementless fixation, and indeed, this was a wonderfully precise tool for preparing the femur. However, in the early experience, there were soft tissue injuries to the hip abductor muscles, and patients suffered hip dislocation, and this was largely abandoned in the United States, and further development proceeded overseas. Computer navigation was an alternative, keep the tools in the hands of the surgeon, but give the surgeon more information. So optical trackers were utilized to help understand where the bone is, allowed the bone to move, and the surgeon and assistants to move around and get the angles they needed to do the work they needed to do. But the bone preparation was less precise than the assessment because there weren't really great precision tools to achieve what you could measure. They generally focused on the socket position in hip replacement and limb length and offset. They referenced the bony landmarks for the plane of the pelvis, the anterior superior iliac spines, and the pubic symphysis to figure out where is the pelvis and where should the socket go. Again, the goal here was to optimize cup position and limb length. And this had incremental benefits in terms of precision, but a small market share really never moved the market. So what's current? Why are we all of a sudden having a surge of interest in technology and hip replacement? Well, the haptic robot really changed the game by introducing CT-based preoperative planning and a precision tool to not just help you measure where you're putting things, but to actually accurately prepare the bone exactly where you want to prepare the bone at the exact position and angle, and to implant the device with greater precision, particularly on the socket side, and then to navigate the femur as well. So this has now been around since 2012. So we're now in the 11th year of robotic hip replacement in the United States, and the 10th year in my personal experience. But there have been a lot of alternatives that have come out and have kept costs and bulk out of the operating room. So in-wound navigation gives us a lot of the same precision information without a robotic tool, but with not the sightline issues, not the cost issues, not the inconvenience issues of robotic technology. And then, but still with pins and arrays and things that feel like navigation and don't feel like doing surgery, along the way. And then there are these other tools using fluoroscopic navigation. So putting together a series of X-rays to create a calibrated X-ray, allowing us to see the angles at which parts are being implanted in real time while we're doing them under X-ray guidance, not just to see the picture, but to get millimeters and degrees of angles and to get real-time information about how we're implanting devices, particularly from an anterior approach. And there are the earlier generations of these and also some more current ones that also dovetail with computer templating software to help choose the ideal size and shape implant and even predict how things would change were you to change a modular part on an implant. So lots of powerful tools that are becoming available to us in the operating room to execute our surgical plans. So despite all the differences between these tools, which are sort of highlighted in gray, whether they're imageless or image-based, whether they're passive navigation or haptic robotic arm-guided, all these tools currently share the same basic targets. They seek to reduce the risk of dislocation and limb length discrepancy by measuring and guiding our acetabular component position, specifically anteversion and inclination. Many of these tools also help guide the center of rotation, particularly like the haptic robot. Other tools give a little bit less control or information about center of rotation. And then they help give information on length and offset, mostly on the femoral side. And some of them give some information on femoral anteversion, whereas others do not. And we've seen that computer assistance certainly does improve our accuracy and precision. A meta-analysis looking at almost 1,500 total hips showed that we achieved our targets about 80% of the time, and we as in surgeons, this is a meta-analysis, about 80% of the time with computer navigation versus 63% without. Now, those numbers don't sound all that amazing, but this is with older navigation. But when you look at how this translated to clinical outcomes, we saw that this really made a difference. So the dislocation rate was 1% with navigation versus 2.5% without. So a statistically significant and clinically significant reduction in the risk of dislocation, less than half the rate without computer navigation. But why do we have any dislocations if we have precision tools? The answer is because the specific position where you put the cup is not the only thing that matters to prevent dislocations. It turns out that lots of our dislocators are in zones for component position that we previously thought were safe and acceptable. And so the next generation haptic robots is not just hitting the traditional targets, but finding new targets, and we'll talk about that in a second. But the sort of second generation of robotics, these haptic robots, have real benefits. Fewer radiographic outliers do result in fewer clinical outliers, fewer patients who are dissatisfied, fewer dislocations. And that's been shown in the past in 2014 by Rich Ilgen in Wisconsin, and then more recently from our neighbors uptown, showing fewer dislocations versus manual and navigated surgery when a robot is used for posterior approach hip surgery. But I'll be the first to admit that the benefits of robotic surgery aren't always obvious to every patient or every surgeon in routine cases. Most of our hips don't dislocate, regardless of whether we use technology. And there are other ways to prevent or reduce the risk of dislocation. And while robots and technology have reduced the risk of dislocation, they have not eliminated it completely. And the answer here, we probably need patient-specific targets, and there may be other issues that are not just about component position. The benefits in more complicated cases are far more transparent. When you have cases of bone loss and sublux joints, the ability to really see where a component is going to fit relative to the bone, choose exactly how proximal or distal you want the implant to be to reconstruct a patient's bony anatomy while getting their biomechanics correct. But also resting on healthy host bone that can support an implant, finding the right compromise in these cases with more severe dysplasia that are highlighted here, or patients who have substantial pelvic obliquities or sublux or dislocated joints, and being able to put things together so that routinely it kind of just looks like you did this on purpose. And when you look at the postoperative X-ray, you can't really determine that it was such a complicated case preoperatively. That's really what the robot, where the robot currently shines. So what's new? I think it's really the incorporation of information about spinopelvic mobility into the cup positions that we choose with these precision tools. So we know that with normal spinopelvic mobility, the pelvis tilts backwards when you sit, and it tilts forwards when you stand, and this protects against dislocation out the back when you sit and out the front when you stand. Patients who have abnormal spinopelvic mobility, who have a stiff or fused spine, they can be stuck with an anterior tilt, which is sometimes called stuck standing, which means that their functional anteversion isn't as good when they sit, so they're at risk of posterior dislocation when sitting. And so we actually have to antevert our implants relative to their bony anatomy to achieve at least 30 to 35 degrees of seated anteversion and reduce their risk of dislocating out the back. Whereas patients who have a posterior tilt, who are stuck sitting, they have increased functional anteversion, putting them at risk of anterior dislocation when standing. And so in these cases, we may have to retrovert the implant slightly to anatomy to make sure that the standing anteversion is less than 30 to 35 degrees of anteversion so they don't dislocate out the front. And this also helps, or we do want to stay inside the anterior wall to avoid psoas tendon irritation. So sort of 2.1, the next generation of robotics was incorporating some of this information. This is some work that I did in which we looked at the initial plan relative to just the bony anatomy. We then adjusted it slightly to compensate for femoral anteversion on the basis of a combined anteversion philosophy where the total of femoral and acetabular anteversion should hover around 40 degrees. We then made subtle adjustments for sitting and standing pelvic tilt, and this was done just by our own impression of whether we should add or take away a little bit based on the information from the prior slide. And we tried to hit the target with a robotic arm, and we showed that taking those considerations improved our functional cup position. So before we considered the sitting and standing pelvic tilt, we got our targets for standing cup position a certain percentage of the time, and 85 or so, and we got it up to 93 or so when we started considering the pelvic tilt. And so consideration of pelvic tilt improved our functional positioning, but this was done without the support of the software. The more recent software package actually allows you to plug in the patient's sacral slope in sitting and standing, and then to model where the pelvis will sit. And you can even model impingement-free range of motion. So this is a case demonstration where they showed that this patient had a prominent anterior inferior iliac spine, and it was evident that they were going to impinge there in flexion. And by selecting a longer head, they got a more length and offset, and that selection of additional head length and offset eliminated this impingement in flexion. So they were able to choose a construct that was less likely to impinge and dislocate, and then use a robotic arm to achieve that target reliably. So the rise of tech is happening, but the question is, what matters? Do we really need a robot to achieve this? Can some form of computer navigation deliver adequate accuracy and precision? Would that be cheaper and faster? Yeah, it probably would be cheaper and faster. But the question becomes, is it enough accuracy and precision to link it to the imaging and to have a complicated plan? I think on the one hand, it's wonderful to avoid the need for preoperative imaging. On the other hand, as we get to more and more sophisticated targets, whether it's exactly where that knee should lie or exactly where that hip should be to prevent impingement and dislocation, but not stick out at the psoas recess, the three-dimensional information that we can get from preoperative imaging really helps us to have more sophisticated plans for what we do. So cheaper and faster may or may not be better. And we do want tools to reliably prepare the bone because, of course, dislocation isn't the only complication that we're looking to prevent. We're looking to prevent loosening and other mechanical complications that do result from bone preparation. And so a lot of the focus has been on dislocation in hips, but the tools that help us most reliably prepare the bone, machine the bone to accept the implant reliably are going to be the ones that win the day, I think, in the long run. Do we need preoperative imaging? We just talked about this, but my point is that I think the information from dynamic imaging is probably essential for having our accuracy and precision matter. Because if you don't have that sophisticated idea of where this person's implant goes, being precise around the wrong target probably doesn't help very much. Although certainly it is possible to get additional information during surgery. And so one of the really interesting things is whether we can get the dynamic information through imaging during surgery to help make decisions so the patients don't have to travel, and we can recalibrate and readjust, even if we lose a bony landmark or something during surgery. So the ability to re-image during surgery and to use that imaging information with robotics is going to be a powerful thing in the future, I believe. Do accuracy and precision matter? The funny thing, when I've been talking about robotics in hip and knee replacement for a decade now, and this was a really big discussion. It was debatable. Does it even matter? And the reality is, I think everybody's gotten on board that accuracy and precision matter. We just have to find the right targets. One of the interesting questions will be, does AI and technology, does it end up giving us more information about who we should and shouldn't operate on? We do all this focus about, where exactly should we place the cup in this patient with a 10-level fusion who's at risk of dislocation. Maybe we're just going to learn that patient with a 10-level fusion is at such a high risk of dislocation wherever we put the cup that maybe this is not an ideal person to offer a hip replacement to. So it's going to be interesting as we get more and more modeling of, what's the expected outcome of surgery in a patient, and what do you tell a patient who has been modeled that they're at excessively high risk for surgery? Are we going to withhold surgery from those patients? So there are moral and legal implications of the information that we're going to start to get from technology. But will our patient-specific targets reduce dislocation? Really only if their models are good enough, right? So we need to not just focus on the socket, but incorporate the femur. This cup is in the perfect position in this person with a complex, extensively fused spine to allow sitting and standing, but the femoral component doesn't have enough anteversion, and so they end up impinging because of their femoral retroversion. So this patient needed a revised femoral component. And then does the pelvic motion change after restoring hip motion? This is a patient who had a severe pelvic obliquity before the hip was replaced, and then we got rid of their adduction contracture and their pelvis came down. So predicting whose pelvis is going to move before and after surgery is going to become important. And the reality is our patients also have late spinal degeneration after surgery, and so we have to place our cups in places that will tolerate those changes in the future. And of course, we need precision tools to accomplish these patient-specific targets. And even the proper bearing is probably necessary. And there are those who argue that we don't necessarily need precision tools. We just need better implants that forgive the fact that the socket is 5 degrees this way or that way from ideal. I probably make the other argument. Technology is showing me that some of my patients only have a very narrow 2 or 3 zone where I can safely put a cup. And even there, I need a little help. And so having these larger diameter bearings, whether they're fixed bearing or dual mobility, whether they're a little bit more than a hemisphere or a little bit less than a hemisphere, the optimized bearing with the optimized position is probably going to be the marriage that helps prevent dislocation in these really high-risk patients with extensive fusions. So what's next? What will the third generation of robotics and hip replacement be? I mean, this is a question nobody really knows, but what am I hoping for? What am I looking for me and for my patients? We certainly would like to enable less invasive surgery for faster recoveries. So if we can decrease the need for visualization with the surgeon's eye or enable off-axis bone preparation so we don't have to have a straight shot for everything, that'll help us cut less. If we can improve the femoral side, whether that's by using the computer to guide the neck cut and the canal entry point for perfect broaching, or whether it's for machining the bone in a way that allows us to control our version or use implants that allow anteversion control for us to dial in the femur just as precisely as we're dialing in these acetabulum these days. We're going to use artificial intelligence to optimize our patient-specific 3-dimensional targets. Based on an anatomic and functional analysis that includes the spine and the pelvis, the cup and the stem. And it's going to look at not just an impingement, but optimizing the full range of motion, minimizing edge loading, optimizing the joint reaction forces at the hip. It'll allow us to implant improved prostheses. In knees, the robots have allowed partial knee replacement to be a more viable option than it was with manual instruments, because that was a technically demanding niche procedure. You can certainly imagine that robots could be a part of bringing resurfacing back in terms of ideally preparing the bone to accept these resurfacing implants in an orientation that doesn't lead to edge loading, doesn't lead to notching the femoral neck and femoral neck fractures. And there are even different kinds of designs of implants that just aren't practical to implant manually, but that could be designed for robotic insertion. Could be applicable to revision surgery, both in removing implants and cement and addressing bone defect and deformity correction. And I think one of the big question marks is, will surgeons embrace greater robotic autonomy, the sort of back to the future of the robodoc, the robot that can act on its own? The answer is probably only if it both increases quality and efficiency. If it takes twice as long or if it deteriorates any outcomes, we're not going to tolerate those things. And surgeons will certainly embrace a technology that reduces reliance on assistance. So we like to be independent, but if we can be dependent on a tool that's reliable instead of on others who may or may not be reliable, that's certainly going to attract surgeon interest. Rapid and autonomous bone registration and preparation that saves is going to be required to make it more efficient. And hopefully, if it can improve inventory management and result in the need for fewer surgical instruments, it can end up reducing rather than increasing costs. Will manual surgery someday become obsolete? I think that's an interesting question. Well, only if robotic surgery both increases quality and efficiency. And if overall artificial intelligence and robotic surgery combine to both reduce complications and improve satisfaction. I think reducing complications is something that that surgeons care about and patients care about when they think about it. But most patients don't have complications. And so the market only moves when the typical outcomes get better. And so it's not going to be enough to reduce complications. We're going to have to improve typical outcomes, improve satisfaction before robotic surgery really takes over the market. But that's probably possible. Not only can we can start targeting things that we haven't been targeting before. If we realize that excessive changes in the anteversion or in the hip offset can affect our psoas or abductor tendons through abnormal biomechanics, and we can change that. Or if we can make decisions about femoral anteversion that not just optimize the range of motion of the hip, but make sure that we don't cause internal torsion at the knee, or the foot. We don't have in-toeing or out-toeing, or a knee that becomes functionally valgus or varus because of the choices we made at the hip. As we start expanding our view outward beyond the hip to consider the entire kinetic chain, ultimately, technology is going to allow us to consider a wider field of inputs and control a wider group of outputs. And I don't think there's any turning back. So that's my talk. So following my talk, Dr. Claudette Lajam, who's one of our professors of orthopedic surgery at NYU, is going to enlighten us on the role of XR and augmented reality and all sorts of tools from fighter jets to forceps, I guess, in joint replacement and the metaverse and everything.
Thanks, Matt, and thanks, Mort and Vinay, for letting me join you today and talk about this. So we're going to switch gears a little bit and talk about maybe what the future is and different types of technology that we can use in arthroplasty and in teaching. These are my disclosures. I do have a potential conflict. I am an unpaid consultant for a VR company. So here's our game plan. What is XR? Where are we now talking about surgical training and as a surgical tool? And what are our future applications and opportunities? So if we think about the future and the present here, this is what we have as a potential. This is a craniotomy, obviously not orthopedic surgery, but you have traditional outlining of the tumor where they're trying to, okay, I think the tumor's here, I'm going to mark it and draw it. And then you have this augmented reality potential where you're wearing glasses and you can see the tumor in the head and mark it around based on that. So there's a little bit of potential here for making our surgery safer and better. So let's talk about what XR is. XR, when I say XR, I think it's an X-ray. So let's go through some terms. A virtual environment is a 3D synthetic world or scene that's viewed interactively by a user, and that's usually us. An immersive virtual environment is a virtual environment that surrounds the user in such a way that the physical reality is substituted and replaced by the virtual environment. A virtual reality are technologies which create this immersive virtual environment or the experience of using one. Augmented reality is a 3D environment that combines real and virtual imagery, is interactive, and is registered. Now, this is not new. This was coined in 1997, this term. And XR is basically any of these families of technologies. It includes VR, AR, and mixed reality. Mixed reality is the continuum of all technology that we blend real world with virtual world. And this, again, not new, 1994, that term was coined. Now, what's the metaverse? The metaverse is even bigger. There are 7 layers of the metaverse, and there's so much potential for what we can do that it's kind of mind-boggling reading about this. And right now, we're pretty much here when we talk about, VR, AR, XR, what the technology is. So typically, you have information that's stored somewhere, and that information is used to create models or data. Then you have a computer system that processes the data. Then you have a rendering software. So that rendering software translates all this information to a user through some interface. Then the user receives a stimulus, and then the user responds by inputting. And then the input device interprets that, and then the computer processes it again, and it goes and it cycles, begins again and again. So we have data, processing, rendering, and inputs. We have people, which are the users, and then there's systems of people that can use technology. So technology in VR and XR is not brand new. In 1968, that was invented the first augmented reality headset or virtual reality headset. And as you can see, it's attached to the ceiling because it was so heavy that the person couldn't actually wear it. Then you have 1986 when NASA had a famous cover of a magazine that had the astronaut wearing the headset, and with her hair basically was glued to the wall. It's very famously. And then in Scientific American in 1987, there was an article about virtual reality and mixed reality. So like that helmet is very interesting. So the real change in the virtual reality headset happened when the rendering software, the helmet, became a product that could be used by consumers. In 2013, the Oculus Rift Development Kit 1 was released. So that thing that was attached to the ceiling was sort of that NVIS SX11, which is on the left side of this graph. And that had a field of view of 102 degrees, and the Rift had close to that. The resolutions were almost the same, but the weight was tremendously different. The Oculus Rift had eye tracking involved, and it was $300 versus $30,000 in cost. So this changed the game here. Now, when we talk about new technology, you have to talk about the Gartner Hype Cycle. The Gartner Hype Cycle is a system that's used to track new ideas and new technology through several phases. There's the innovation trigger, the peak of inflated expectations, the trough of disillusionment, and then the slope of enlightenment. And if a new technology can make it through all these things, it can eventually be matured and end up in production, and people use it. Consumers will use it. So this on the left is the augmented reality evolution. And the Gartner cycle thought that in 2018, they thought that the augmented reality would mature in about 5 to 10 years. But it disappeared off of this chart the following year. So that meant it was already mature. It matured much more quickly. Same thing with virtual reality. This was, again, in 2017. It thought, oh, it's going to be 2 to 5 more years before it matures. And it fell off the cycle the next year. So these technologies matured pretty quickly. So where are we now with these technologies and surgical training? So again, we have our look at this through the lens of the materials that we use in virtual reality. We have data, we have processing, rendering, and inputs. So our data are published materials, our surgeon experts, and industry. Our processing systems are you've gone through existing vendors and games. There's all sorts of software out there. Our rendering software are either commercial or proprietary, and our inputs are either commercial or proprietary. So there's lots of people who can use these types of technologies in surgical training. So let's talk a little bit about motor learning. Motor learning is very complex. In the brain, it involves the primary motor cortex, the angular gyrus, and the parietal lobe, and it's a very complex thing. But a simple motor process like riding a bike is pretty straightforward. You move your pedals, you steer, you look. And these are chunks of visual and spatial elements that people learn. Now, cognitive learning, which is what we do in surgery, is a lot more complex than that. So it's not just riding a bike, it's racing a bike. You're not just worried about turning the pedals. You have to pay attention to lots and lots of things. It's managing complexity, using the hippocampus and the right brain, and learning in a very different way. And also training your intuition so that you behave appropriately, even under stress. And memory is better when you have a tactile feedback. We're surgeons, so we know this. We like having tactile feedback, but it's been proven that certain things improve memory. Writing notes by hand, for instance, and this is a study performed that showed that folks had more memory retention when they wrote things by hand. And it also lit up more on MRIs when people were writing notes by hand. How do we apply this to surgical training? Doing things by hand, practicing by hand, writing things during surgery. Let's talk about fighter jets. Where do fighter jets come in? Colonel John Boyd is a very interesting guy. He was a fighter pilot who, quote, changed the art of war. And this is a great book if you haven't read it. It's a very good, interesting biography of him. He flew the F-86 in the Korean War, and he was a weapons instructor for the Air Force. And he was obsessed with tactical strategy. He also worked on developing the F-15, the F-16, and the F-18 fighter jets. And he developed something called the OODA loop as a combat operations process to teach people how to fight. And the OODA loop is used in a lot of platforms. So let's look at this. So OODA, O-O-D-A, observe, orient, decide, and act. And this is what we go through when we're doing surgery over and over and over again. We look at something, we say, all right, what does this mean to me? Then you make a decision, and then you decide what you're going to do, and then you do it. And then if you do it, then you see what happens again, and you go around in circles. Now, does this look familiar? Yes, because that's how virtual reality works. You have information, you have a way to render it and process it, you have a way for it to be presented to you, and then you act, and then it goes back and it does this again. So virtual reality is really, it fits in. So, fighter pilots were found that those who moved through this OODA loop faster had a tactical advantage. So agility would beat raw power. And this is true way back to 480 BC in the Battle of Salami, where the Persian army and fleet, which was much bigger, were defeated by outnumbered, smaller, and more nimble Greek trireme boats. The Greek infantry also had lighter and stronger armor, so they were more nimble. So this is not a new concept, but we have new ways to do it. So here's it is again. Observe, orient, decide, and act. Now, we can go through these things very slowly, or we can go through them very quickly. So that's where the concept of latency and speed comes in. If you can move through this loop quickly, and if you get interrupted, you can get back on the loop, you do better than folks who don't. So in surgery and combat, have a lot in common. So there's risk, there's a lot of stress, there's high cost involved, and you want to be able to reproduce things so that when people practice, they can practice and get better at it. And both of these things, it's very difficult to reproduce, say, a complex surgery or an air battle. So they're very similar in those ways. So how do you analyze this? Talking about risk, our traditional training was always a graduated responsibility model. Some learners would need more repetition than others, and then new procedures involve a learning curve. So how can we learn while we minimize risk to our patients and also to ourselves? That's something that COVID taught us, that when we go to work, we sometimes put ourselves at risk. And COVID did teach us this. And these on the right, there are two examples of things that I think surgeons are having to relearn how to cement stems because we forgot how to do it. And now we have to relearn. And also, when folks were learning how to put a resurfacing in appropriately, there were a lot of mistakes. We did a study at NYU, one of our former residents, on cadaver total hips, where half of the participants had a VR training prior to their cadaver hip and half didn't. And there was a statistically significant improvement in the technical performance of those who did a VR session before. And we used the PGY-5 residents to help determine whether the younger residents needed assistance. So what does haptics have to do with it? We've been talking about haptics. We did a study here at NYU also on tibial drilling, where we had PGY-1 residents, and they did a sawbones drilling after they practiced with virtual reality. But what they didn't know is that the virtual reality was randomized to either have the haptics on or the haptics off. And then we measured how far they over-drilled the sawbones tibia. All the trainees learned how to drill, but the haptics learned much faster. So the VR, even on the VR training, they were more consistent. They plunged through the cortex significantly less on the sawbones after the training with haptics. So here is overdrill on virtual reality. So the non-haptics were the dark bars and the haptics were the light gray bars. So you can see that they overdrilled less immediately on the first rep. And then on the sawbones, again, they overdrilled less on the first rep. And that's really important when you think about teaching someone to do something that's dangerous. If you can prevent them from messing up on the first rep, that's a win. Stress. How do you make stress? How do you build stress into training? Complex decisions in surgery are frequently made under duress or under stress. And when you're stressed out, it may affect your performance. There's the Kahneman and Tversky developed this two-system model where there's two parts of your brain. There's an intuition part of your brain, and there's a deliberate reasoning part of your brain. And it's hard to use both of those at the same time when you're under stress. So learning under stress can help cement the correct decisions into your intuition so that that intuition guides you the right way. Now, can our immersive tools like virtual reality create just enough stress without stressing you out so much that you can't learn anything? Now, that's a challenge we have. Let's talk about cost. Most of our surgeries now are moving to same day surgery or ASCs. And when we try to teach people things, we need them to be, fast and efficient when they do them. So how do we teach them without having them slow us down when we're actually in the operating room? Orthopedics and spine and ASCs are going to continue to grow in the next 10 years in the outpatient setting. And payments are not going up for this. So we need to do more of these surgeries in order to keep our places under, in the black. So we have to teach people things before they actually get to the operating room. There's a lot of cost in training people in general, even people like me who want to learn a new technology. So when I learned how to use a robot, they had to take me somewhere. They had to spend a whole day, have cadavers, have conferences, certify me. And it's tough to do that, and it's expensive. Training OR staff to do new things is expensive. Then we have a whole workforce issue for industry that they have to train their implant sales force. There's a lot of cost to this training. And when you're trying to develop systems that are going to help train you, you have to consider what you're going to invest in. Are you going to invest in hardware or software? Software generally is more cost effective, so you can upgrade it as time goes by without having to do new capital expenses. And also, if you can just use commercial technology that's on the market, that's great. So we may already have a gaming headset, so we could use that for training. We want to make sure that our quality increases as our cost increases, and that's where the ICER comes in. We want to measure and make sure that we're spending money, we're getting a quality return on the investment. This is more relevant after COVID. So in 2020, I asked our residents and our staff who owned a VR headset. 51 people responded. 21% of them didn't even know what it was in 2020. In 2022, I did this again, and almost everybody knew what it was. Administrative costs for training are high, and there's also not great reproducibility. There's a lot of variability in evaluators. For instance, our department, this is our Zoom meeting during COVID. This is only one of 4 pages of us. So there's a lot of us in our department. How are each of us going to subjectively evaluate residents, but have that be a fair evaluation? Because all of us are going to look at them differently. So how can we objectively measure performance when we train people? Well, a virtual reality type of training system is much more objective, and you can get metrics out of those modules without having as much subjectivity. So this is just an example out of one of the VRs that looks at a learning score and then a surgical gaze score. It's like, where's the person looking during the surgery? And you can see learners learn differently, and you can identify where people are having problems by looking at their data. And here's an example. You can, do a surgery, give them the students' questions, the learners' questions, and test their knowledge, and use, published literature and textbooks to ask those questions. And you can have them do technical tasks to learn how to do the operation at the same time. So there's a lot of power in this. So you can go across long distances. So this is me in the big screen, and this is a resident in England, a fake resident, listening to me teach them about a STEM, and you can see the view that they have against the view that I have.
And the change in shape is here, so it gets wider. And
so I'm just using a headset in my house in New York, and this person is in England, and they can see me pointing to different parts of that stem with my hands. I'm not even using any kind of equipment.
The kind of stem you use based on your anatomy. You can see it. So
how do we use it in surgery? So again, latency in surgery equals safety. So we want things to move quickly in the software so that it doesn't let us make a mistake. Here are our users. So navigation and robotics, we have these rendering software. Usually it's a screen, and our input softwares are probes, markers, and pressure sensors. So, this is what we're using in the operating room. We're doing this already by using these technologies that we're talking about all day today. Here's an example of, I'm looking at this screen and I'm putting in inputs and I'm planning this and I'm trying to get this plan. And, this was my plan and this is what I got. And that's pretty cool that I was able to do that with technology and with basically a mixed reality robot. And here's, using the robot, I'm pointing my rendering technology. My input is a probe, and my rendering is the screen that I'm looking at. So we're using this now. We have lots of things that are on the commercial market that you can buy. AR glasses, mixed reality headsets. The mixed reality is a little more expensive, but these things are going to be much less expensive and much more available in the future. So we can leverage these technologies that are just available over you could buy them on the internet. Mixed reality surgery is emerging as interestingly, a less costly way to do navigation because there's fewer disposables. The first FDA cleared mixed reality total hip was done at New England Baptist Hospital in 2021. And they used a HoloLens, a Microsoft HoloLens. And the first mixed reality total knee was done by Antonia Chen, my friend at Brigham and Women's, and that was in 2021. And in spine, a pedicle screw MR is being studied. This is me using the mixed reality total knee replacement just this year. So what are our future applications? Well, medical and surgical education, there's tremendous opportunity here. We can integrate VR training for our trainees. We can use metrics to track their milestones and their skill gaps. And we can also train operating room staff or even industry staff to manage their implant systems without having them go to trainings or miss work. What are our opportunities here? There's a lot of cost here. So how do we get money to train our students and pay for these things? Well, we need to figure out if the government can play a role in it, or can we partner with industry? We need to create standards. So when we have these modules, we need to make sure they're validated, that they fit with our current knowledge, and that they're accurate. And then we have to train us because, some of us don't like this technology. We're afraid of it. I remember when the telemedicine first came out, when I was trying to get my patients to show me their knee, I got a tour of their whole house. So this was me trying to have this lady show me her knee, and I was looking at her whole house. So we have to learn how to use these technologies. There's a lot of cost to owning these, headsets and gaming software. So I did another survey, and a lot of folks thought that the cost was a big barrier to owning the headset, and also that we don't have any use for it now. So we need to figure out how to make it useful. This is really exciting. Haptic gloves. I can just imagine us getting up in the morning, putting on our haptic suit and going and being able to operate in a different part of the world. And these, haptic gloves are actually getting less expensive. Now they're closer to $40,000 instead of $500,000. This telerobot is pretty cool. One person can be running the robot wearing gloves, and then the robot can do what you're doing, and you can actually feel what the robot is feeling. It's very, very cool. So is this the future of surgery? Are we going to be able to do this as these technologies get better, remotely and safely? All right, I'm trying to get to the next slide here. Robots are designing railroads right now. So, we can be doing surgery with them potentially in the future too. Rendering devices, like our inputs, what are we seeing and how are we interacting? So making it smaller. What about a contact lens? Why don't we need better batteries. We need lighter technology to be able to do this. We're not really there yet. This is the contact lens that exists now. It's kind of bulky. I don't think I want to wear that in my eye. And this is the resolution you get with this contact lens. Maybe the holodeck. I'm a big Star Trek fan. So, what about going into this room and being able to virtually interact with someone in some other part of the world by creating this complete virtual environment for you? The metaverse can be dangerous. Right now our computer systems are pretty centralized. When you think about our future state, there may be decentralized systems like blockchain they use for Bitcoin. And decentralized digital identities. How do we keep ourselves safe in the metaverse? We need to be sure that our personal data are entrusted when they're entrusted to these technologies, that they're safe. So this is part of the future, and maybe our patient privacy can be still protected with different ways of using technology and systems. There are also bad actors on the metaverse. There's cybercrime, there's bullying, there's abuse, there's cheating. So we have to be careful of bad actors and be suspicious of them and pay attention. So, the wrap up, XR is here to stay. There's a lot of potential for education. We need better data integration. We need people to make modules so that these things work, and that costs money. We need technology to improve. Our potential for using these things as a surgical tool is great, and we need to improve the technology so we can interact with it better and validate it and make it safe. We can have a role in creating these tools. We need content and we need funding. We need to lead the way. We can define and validate new technology. We have to remember about privacy, and we have to be ethical. Thank you very much.
Thank you, Dr. Lajam. We're almost at time, and I want to respect everybody's time, but we did get some questions from the audience, and so I'm going to ask some of those questions to members of the faculty, and I'm just going to request that you keep your answers to 2 or 3 sentences so we can get through the questions and also allow people to get to their evenings. So the first question that was asked what have been the obstacles to adopting technology over the last decade, and have we reached a tipping point, and if so, why? Mort, what do you think about that?
Yeah, I had a slide about this, and I've looked at the international communities. So basically, the value, which is what the robotic platforms or these technology bring in as compared to the cost. And there's some things in terms of adaptation, the line of sight, and the implant that comes with that technology. But again, they're just tools. We need to define the goals with them.
Okay, great. I also just think, frankly, as other companies have gotten into the game, instead of it being a group of companies arguing you don't need this tool, now it's you need my tool, right? And so, frankly, it's having competition has probably helped us get to a tipping point to a certain extent. There was another question, and Vinay, I'll ask you to take this one. If avoiding soft tissue releases is a goal of personalized cuts to achieve kinematic alignment, or in a robotic knee replacement, are patients with chronic acquired deformities, poor candidates for patient-specific total knee? Is this for our blue-collar retirees? So the question is basically, what's the limit on the deformity you can tackle in this way?
Yeah, I mean, it's a great question. I mean, Mort pointed out precision alignment for personalized CPAC classification, but there's a ton of patients out there, including in my practice, with horrendous deformities. And I tell the fellows the next phase in technology is going to be doing iterative. It's going to sound crazy for people that have just done one-time cuts and then releases, but iterative technology balancing. In other words, you have to basically register, release, cut, and then go back and then register, release, cut where you are to get the perfect knee. Now, I fully understand that people don't maybe have the time or patience to be doing that iterative soft tissue release and then recut, when you could just do one cut and then release all your ligaments the way you normally would. But I think that by doing the technology associated iterative cuts, we may, by doing a couple of things, minimizing the amount of bone we cut in the beginning. And secondly, maybe avoiding massive soft tissue releases in general. There are massive deformities, however, don't get me wrong. You're going to have to release soft tissues in some deformities. We're not trying to avoid releasing anything in big deformities, because you're just not able to put implants in 15, 20, 30 degrees of whatever, varus, valgus, flexion, extension, etc. So, the restriction.
And I think a lot of that is because the implants just aren't designed for that. Like Correct. They're designed for the mechanical alignment, not Correct. This way. So maybe the future is just designing implants differently.
Yeah. But I mean, there will be a tolerance to them as well. But I think that's a good point. The design will evolve as our technology evolves. But yeah, there's no question. You have to go back to the basics and understand what to release when you can't use the technology.
Great. One of the physical therapists who has been listening just made a comment that, observing, yes, I am seeing better results with robotic and computer assisted surgery. I think I want to both validate that. I think we are also, but also say it's hard to make these assessments. The reality is the patients who seek out technology associated surgery may be some of our most motivated patients. And so even for those of us who've made changes in our practice and say, I'm now using technology and my patients are doing better, the reality is that the use of technology may also be attracting the patients who have other attributes that make them likely to do better. So it's important that we all be self-reflective and we use data with to analyze our outcomes and more randomized comparisons. Our sequential experience, whatever we're doing now, seems to work better than what we used to do 10 years ago. That's certainly been my experience. But it's connected to that. Is there a learning curve using robots in joint replacement? What do you think, Dr. Lajam?
Oh, absolutely. I mean, just like with anything, you have to learn how to do all of the tricks. I mean, you get better at it. You figure out how to troubleshoot when things don't go well, and how to use the technology more efficiently. Like, okay, I know that if I do this, the pins are going to go in right. Or if I do this or move the table back a little bit, I know I'm going to get better line of sight. Or I know if I don't pay attention to this part, I'm going to have to redo the registration. So there's lots and lots of things that you learn as you go along and you get better at it. But then it gets pretty quick. Right now, my robot hip is faster than my manual hip used to be.
Yeah. Yeah, I think that's exactly been my experience, is that, I think the accuracy and precision is there from the beginning, because the tool is the tool, but our ability to use the tool for good, to understand its power, to not just use it for the goals that we had before we became robotic surgeons, but to use it for the goals that we didn't know we should have. Those things certainly evolve over time. What about leg length discrepancy after hip replacement or after surgery in general? Dr. Aggarwal, you want to give us some insights on why that sometimes happens and why we have to fight against it?
Yeah, I mean, it depends on, hip replacement. Obviously, one of the big things that we've evolved is acceptance of limb length discrepancy. I think back in, 30 years ago, people would accept a lot more, as you mentioned, in terms of precision, leaving the OR with their implant positioning, but also patients would probably accept more. Nowadays, they're demanding a lot more precision from their surgeons, and that includes limb length discrepancy, right? We want to leave the OR with that restoration of limb length and offset to what the patient should have natively without arthritis. And that can be helped with things like, preoperative imaging planning, so that you can put the socket, for example, in exactly the right height that you would have wanted to give yourself a chance at getting limb length, and then planning your head size and your neck length on top of that. That's something that we hadn't been able to do before. You can use intraoperative things as well now, which I do, in certain approaches to the hip, right lateral position, posterior approach, direct lateral. You may not have that perfect ability to judge their limb length sideways until you're back supine or with x-rays. So I think that that's where technology really helps. And I used a lot of technology to help gauge my limb length. Now, I will tell you that there's no perfect, because there's something called perceived limb length, and just getting it, not getting into the weeds with this, you have to get them radiographically where you think that the patient's going to be happy. But you showed a pelvic mobilization x-ray earlier. You don't know. We're not good at predicting what the patient's going to do after 2, 6, 3 months, 12 weeks of therapy. So we try to get it more accurate than we were 20 years ago, is the short answer. And I think we've been successful at doing that.
Yeah. There certainly is a lot more that goes into it than just putting back the same amount that we measured in terms of the changes in soft tissue tension and pelvic obliquity, scoliosis. A lot goes into it. So a complicated topic. You mentioned anterior or different approaches, and one of the audience members asked about are there studies with the successes of anterior versus posterior approaches for hip surgery, and do you use robotics for anterior approaches? As one of the panelists who does both of those approaches, I'll take that a little bit. There are a lot of studies comparing anterior and posterior approaches for hip surgery, and the conclusion more or less is that the long-term outcomes are the same, but that the short-term outcomes seem to favor the anterior approach, showing a slightly faster recovery, at least in the hands of experienced anterior surgeons. But within several weeks, the results are very comparable, and each approach has slight advantages and disadvantages in terms of complications. So the risk of dislocation may be a little bit lower with an anterior approach. The risk of a problem with the femur and the femoral attachment of the device may be a little bit lower with a posterior approach. But the overall risk of complications in the hands of an experienced surgeon isn't substantially different between approaches. And so, frankly, the reason they're both still out there is that they're both good approaches for doing a hip replacement. You need to have a surgeon who knows how to do that approach. When it comes to robotics, a robot can be used from either approach. Fluoroscopy, intraoperative X-ray, is a little easier to use from an anterior approach. So there are many of us, and myself included, who lean more in the direction of fluoroscopically guided navigation for anterior hip surgery, and more in the direction of robotic surgery for posterior hip surgery. But there are exceptions in each direction. I think you want to, this is a panel of technology believers. So I think most of us want some form of technology to augment our own perception and to make as one more double check. And then we want an approach that we can deliver a good outcome for our patient. And I think either way we can do that. There was another question about the different robots that are out there, and how do you choose with all these robots for knee replacement these days? How do you choose, and does it make a difference? Mort, do you have an opinion on that, Dr. Meftah?
Yeah, sure. I think it's a matter of personal opinion. What I would suggest is that get familiar with what are the differences between them. Of course, if you're an image-based robotic platform, you have to deal with authorization pre-op and radiation, and also the implant that your institution will use. That dictates some of the restrictions in terms of the technology you can bring in, because a lot of robotics. Again, as Vinay mentioned, except one, they're all tied to their implant. The other thing is that some of these user experience are different, so understanding what to do with the ligament balancing graft might be challenging in one platform versus the other. So my suggestion is try them all of them, or the ones that you think would be more aligned with your institution and your goals, or the implant of choice, especially in a cadaver lab before adopting them.
I'll just chime in and say, just to reiterate earlier, it's a lot like what we're doing with implants at this point, right? It's become, as Matt said, each company kind of has their own technology associated with it. And now it's going to be up to registry data, right? That's kind of how registry data has helped us with certain implants and telling us what maybe the bad actors are. I think similarly, robotics is going to undergo certain studies with registry usage to see which one is truly superior, if any. Until we get to that point with enough data and numbers, we're not going to really know. So as Mort said, go with your comfort level, education, and implant.
All right, Dr. Lajam, is augmented or virtual reality an alternative to robotics in the operating room, or will these technologies work together?
It's possible for them to work together. That's a great question. So, augmented and virtual reality are not mutually exclusive from a robotic system, because basically robotics is part of the world of XR. You're interacting with a semi-virtual environment and a real environment. So they are not mutually exclusive. However, there are mixed reality platforms that can be used in the place of other navigation tools. So instead of using a robot screen for robotics, you use a headset instead. So there's lots of ways that you can use those tools in collaboration with other tools in the operating room. You're muted, Matt.
Thank you for that. This far into our Zoom experience, I should have avoided that. So I'll ask Dr. Meftah the next question. Data collection matters with robotics. What about smart implants and sensors? Is there any value there? What does data need it to prove? What do we?
Yeah, no, that's another interesting advancement in technologies. As you know, the personal IQ is the one and only smart implant or implantable device that we have that can capture a variety of different data points, from pressures to gait to potential loosening or an infection. But we're at the infancy of those stages. I think the only way that this would help us is that we have some form of a large database collection, perhaps in artificial intelligence or machine learning, that can follow these patients and give us some guidance about how we can use those data for preoperative planning, because we're still trying to figure out before we implant what are the targets or personalized targets for each patient. It is very exciting, but I think we just have to wait and see how we get with that and how do we manage those data.
Okay, there's basically just two more questions. Dr. Lajam, will milling bone scatter osteogenic material all over, leading to heterotopic bone? Is that a concern, that preparing a bone with something other than a saw or a reamer? Are we worried about new forms of bone prep?
Well, I mean, I don't know that there are any data to back that up. I mean, we do know that certain approaches have increased risk of heterotopic ossification, and really that is a matter of damaging soft tissues. And I think the whole point of all of the stuff that we're talking about is to improve our outcomes by treating the soft tissues better and not needing to get into them and disrupt them as much. In terms of spraying things around, I mean, as long as I think you irrigate appropriately afterwards, I don't know that you're going to be in trouble. But I do think that these techniques do minimize your soft tissue damage and therefore probably decrease your risk of heterotopic ossification.
Yeah, my personal experience would certainly support that. You know, with the robotic unicondylar arthroplasties, which were the earliest robotic surgeries, we burred a whole lot of bone, but the haptic boundaries kept us from irritating soft tissues, and we really did not see issues with heterotopic bone there. So I think we probably generate debris, whether we use a saw, a reamer, or a burr. It's what we do with the debris and how we treat the tissues around it that matters.
I think Vinay and I have debris all over us right now. Probably we just came out of the operating room, so.
So go home and take a shower. The last question I'll refer to Dr. Aggarwal. It's two questions in one. Weight bearing precautions with hip and knee robotic assisted. Does the robot change weight bearing precautions? And then with a total hip, with the robot, does that influence the precautions for an anterior or posterior approach in terms of range of motion precautions?
Yeah, I mean, I think the question here is maybe alluding to pin sites, and I think that if you're using some kind of robotics or technology for knees, you potentially are putting pins, either in the incision in places where you normally wouldn't, or outside the incision, which makes it even a little bit challenging in the femoral shaft, for example, or the diaphysis of the tibia. I do not change my weight bearing precautions. I don't think anybody does with their technology associated joint replacements for the knee or the hip. Just because of those pin tracks are extremely well tolerated. I have heard of maybe one pin track related fracture, but I'm not sure, whether it was technical related. It wasn't mine. I've just heard about it in conferences. So I wouldn't have qualms. Thousands of these have been done nationally now, and it's probably pretty case reportable to have issues with that due to weight bearing precautions. As far as posterior versus anterior versus universal hip precautions, again, that has to deal with your comfort level with activities after hip replacement. We've gone more and more get away from hip precautions in general, with hip replacement having large diameter femoral heads, dual mobility constructs, precision of acetabular component placement. I think most people are getting away from stringent hip precautions regardless of surgical approach, and really putting the onus on our precision of our surgery. But that doesn't really change with your technology unless you've somehow magically lowered your dislocation rate because you weren't putting in sockets in the right place to begin with. So, I think both of those things are, it would be no for me. But again, it has to do with your comfort level.
I'm just going to highlight a case that I did today. I'm not a big hip precaution user, but I had a case today in which we saw in the preoperative planning, this patient had zero spinal pelvic motion, right? Their pelvis didn't change at all when they flexed and sat. And when we did our preoperative impingement plan, we found that we were getting impingement anteriorly and posteriorly, right? We saw the anterior impingement, we wanted to increase our end aversion, but then we got more posterior impingement, and we really were stuck between a rock and a hard place. And so we put it as perfect as we possibly could. We split any more this way, it would be too much posterior impingement, any more that way, it would be too much anterior impingement. So we took the one in the middle, right? and it all went well. But this is somebody who I gave this patient hip precautions because I said, listen, I know that there is some impingement, and so and that was unavoidable. I saw it going into surgery, and I saw it in surgery, and I know I couldn't have put my parts in a different spot, so I'm going to actually restrict this patient's range of motion as they recovered so they can hopefully scar in. And I gave them a bearing that has the best jump distance to reduce the dislocation risk. So I'm actually finding every now and then I'll use selective hip precautions at this point for that patient for whom, despite the fact that we've optimized everything, they are maybe at higher specific patient-specific risk. So for me personally, it's actually not the approach. It's the specific risk profile of the patient in front of me. Anyway, this was a great. I want to really thank all my other panelists, particularly Dr. Meftah, who was my co-moderator, but also very much Drs. Lajam and Aggarwal. I thought there were some great talks, some great questions, very engaged audience, and we're really privileged to have the opportunity to speak to you today. And I hope the audience members learned something. So thank you very much.
Thank you for attending.
Thank you.
Thanks, guys. Great job.